gosh. Hello, welcome. Thank you for joining us today for a live conversation about the coronavirus. I'm Audrey Dutton, health and investigative reporter for the Idaho Statesman. We've been covering the pandemic since before it officially arrived in Idaho in March, and we will continue covering it and its effect on Idaho well into the future. Today, we have a great opportunity to get answers from one of the most knowledgeable people in Idaho healthcare. Dr. David Pate retired this year from his longtime job as CEO of St. Luke's Health System, the state's largest health system. He now advises Governor Brad Little on Idaho's pandemic response as a member of the governor's coronavirus working group. He blogs at drpatesblog.com, and you can find him on Twitter at drpatesblog. We will take questions from the audience later in the program. I'd like to start out with a few questions that we're hoping you might be able to answer that have come from our readers as well as from us. First, we're wondering, at this point, what do you feel safe doing and what do you avoid? Do you go out to eat? Do you go to the store? Tell us where you're at with safety with coronavirus right now.
Yeah, so at this time, I don't do any in-restaurant dining. I do order from restaurants and either get curbside or delivery, but I don't eat inside restaurants. I wouldn't be opposed to eating outdoors at a restaurant where I felt like people were taking precautions and all the employees were wearing masks, but I just haven't had that occasion to do so. I do go to the grocery store. Though I always wear a mask, and I try to pick off times and days. So I tend to go during the work week, and I tend to go early in the morning to avoid contact. And I tend to just go to those grocery stores where I notice pretty high compliance with masks.
And when do you feel like it might be safe to go out and venture out and do a little bit more with your time?
Yeah. Well, I think it just depends on what it is. At this point, one of the biggest risks in Idaho and most common cause of infections that we're seeing is actually family or neighborhood get-togethers. And when I say family, what I mean is that you're having people from your extended family that you don't live with come together. A barbecue, some kind of a holiday celebration. Those are the kinds of things where we are seeing the most spread right now. So I do not feel comfortable getting into groups and gatherings. But on the other hand, I feel perfectly safe to go out and take a ride in my car. If I just want to get outside, have some fresh air, see some things, fine sitting in my backyard and enjoying the nice weather we're finally having. Going for walks. I frequently go for walks with my daughter. And so it really just depends on what the activity is. If it's something that's going to put you in close contact for extended periods of time with people that you don't know and don't live with, I certainly wouldn't advise that right now.
Okay, thanks a lot for that. As we head into fall, what are you expecting as we get kind of the collection of flu and COVID? And what are some of the maybe warning signs or red flags that things might be getting worse?
Yeah. Unfortunately, I'm expecting that we're going to have another spike. We had our first spike in late March, early April. We've just had another spike and we're on our way down. Thank God. That's great. But I would put in perspective that even though we're on the decline, where we are now is we're still having more cases than at the peak of our first spike back in March and April. We have about twice the number of people hospitalized as we did back then. We have about 2.5 times the number of people in intensive care units than we did back at that time. So while certainly it's good news that our cases are trending down, I certainly hope people do not become complacent about that and overly optimistic and thinking, okay, great, now we can go out and do what we want to do, because things right now, even though better than where we've been in the last couple of months, we're still worse than where we were back in March and April. As far as what I expect coming up, I do think it's going to get worse again. And I think that's because of a number of confluent factors. One, we are starting to get kids back in school physically. Two, colleges and universities have reconvened, and students are there. And I really, even though they're all schools, those are two different animals and two different sets of risks. So when I'm talking about schools in general, I'm talking about K through 12. When I mean graduates, I'm talking about colleges and universities, and those are different, but both of those present risks. Also, with the declining cases and the change in the public health district's assessment of our community spread, we're now going to open bars. Now, it didn't go well the first time. I'm certainly hoping, and I do think that those that own bars have seen the consequences if they don't really do everything they can to help control this. But it is going to create an additional risk. In addition, as the weather gets colder, we'll all move indoors. And the more we're indoors, the greater the risk. And then, as you mentioned, cold and flu season. And it's interesting, one of my Twitter followers asked a really great question. Why do I think we'll see more COVID just because it's cold and flu season? And it's a really great question. I think for a number of reasons. Number one is that we do know that kids are a big factor in the spread of influenza. We don't know if that's true for COVID, but it certainly is true of the other coronaviruses, and I suspect it may turn out to be the case with COVID as well. The second thing is, we know you can get infected with more than one thing at the same time, and so you certainly can have COVID plus influenza or COVID plus any number of the other cold viruses. And, this is going to be a really challenging fall because, and Audrey, I know you have a child, but if you think back to a year ago, if your child got sick, likely you kept your kid home from school or daycare for a couple of days, your kid got better, you send them back, and it wasn't particularly a big deal. This year, I think a couple of things could happen. One is everybody will think they've got COVID, and so there'll be a much more demand for testing, much more demand to see physicians for evaluation. And with that, I think that we may pick up more cases of COVID on our testing because we'll be testing more people. The other thing is that young kids, it certainly appears from the evidence that we have so far, don't seem to play a huge role in the transmission as best we can tell right now. It's been postulated, we don't know, but it's been postulated. Maybe that's because they don't have typically as vigorous a coughs. But one does wonder if you have kids with asymptomatic infections of COVID, and now in the next couple of months, they're getting RSV or croup or other things which do cause kids to cough and cough a lot. If it might turn out that they get these co-infections and then have that would otherwise have been missed about COVID because they're asymptomatic, but now they end up increasingly transmitting it. So we don't know. We're going to have to see. This is one of many reasons why I encourage everyone listening to please get your influenza vaccine, and please get your whole family the influenza vaccine, because anything we can do to cut down on the respiratory viruses that we're going to have to deal with this fall is going to help schools manage through this. It's going to help physicians and practices and hospitals not get overwhelmed. So that would be a very positive step everybody could take.
And what's the timing for flu shots? We got this question from a lot of readers.
Yeah, it's a very common question I'm asked. Anytime after September 1st, so you can get it now. And we'd like everybody to be vaccinated by November 1st because it varies from year to year. We can start seeing flu cases in late October. November's much more traditional time. And it takes about 2 weeks from the time you get the flu shot to where you have the protection from the flu shot. My personal preference and what I advise people, if you want to just kind of try to take your best shot at when's the perfect time to get vaccinated, and I put it at the middle of October. And that's when I'll be getting mine.
Middle of October. Okay. And that's for all age groups, should be getting it around then?
It is. Now, let me just add, Audrey, if getting your flu shot is a hurdle for you and it's going to be challenging, and for some other reason you have to go to the doctor next week or something, or you have a scheduled appointment, go ahead and get the flu shot, because I'd rather you get it in September than not get it. So if that's what you need to do it, and that's going to work. What we do is, it's hard to know how long the flu epidemic is going to last here. We certainly can see cases as late as March, April, or May. And so I don't want people to get immunized too soon, because then some of that may wear off by the time we're still having flu cases. On the other hand, I don't want you to get it too late that you start getting. So it's just kind of looking for what's that Goldilocks spot. And I think middle of October is it. But anytime starting now, and please try to get it by November 1st.
Great. Thank you so much for that. So you mentioned that you think as flu and cold season picks up, people are going to be seeking more COVID testing, and they're going to be seeing their healthcare providers more. Is Idaho prepared for that? Do we have the testing capability at this point to be able to accommodate that? We had trouble with that before and have kind of had ongoing trouble during the pandemic. So are we ready for it?
We're getting ready for it. I wouldn't say we're ready for it today, but I will tell you, I'm certainly impressed with the steps that the state is taking to improve our testing capabilities and capacity. I will tell you that it's my personal view that the early struggles were a direct result of a failure on our federal system. But like good Idahoans, we pick ourselves up by the bootstrap, and we've decided to do that. And so Idaho is creating its own solutions, and the Department of Public Health is actually working right now to have set up 7 high throughput labs. What I'm talking about with a high throughput lab is a lab that could do anywhere from a few hundred to a couple of thousand tests a day. And we're working on setting up 7 of them around the state. And this will help. This is being done, and this is a great approach, a private-public partnership. So we're taking providers and particularly like hospital labs and pairing them up with universities and others to actually put this high-throughput testing in place. The problems that we faced before have been myriad. In some cases, it's been a matter of we couldn't get the testing equipment that you need, the actual testing machine. In some cases, we couldn't get the swabs to do to collect the samples. In some cases, we couldn't get the media to put the swab in. In some cases, we couldn't get the reagents for the machines. So there's been a lot of supply chain challenges. Personally, I think we should have recognized this a long time ago and implemented the Defense Production Act to take care of this. But, it didn't happen. We need to learn from that. But now the state has hired a testing coordinator, Brock Anderson. He's doing a great job with Elke Shaw-Tallock and others from the state. And we should have the high throughput testing up and running by end of next month or beginning of November, right in time that I suspect we're going to start seeing this big uptake. And the other thing, Audrey, is previously, a lot of this testing had to be sent to commercial labs. Those commercial labs are not in Idaho. So part of the time delay is just shipping the sample to an out-of-state provider. Having these capabilities in state is going to also help us process this faster.
Great, thank you. We got this question from a lot of people, and I know it's something that you followed and you've written about in your blog. Long-term effects of coronavirus. Obviously, this is still being studied, and we don't know definitively almost anything at this point. But What do we know, and what are we still trying to figure out about long-term effects? And if you can, kind of tell us what maybe you know from prior illnesses that are similar.
So we are seeing some concerning long-term effects. And I'm going to kind of divide my comments. One is I'm going to long-term effects, and by that I mean things that are kind of non-specific and that we can't really ascribe to, oh, this is the particular consequence that you're facing. And then I'll talk about complications, which by that, I'm talking about things that we have seen a particular manifestation like myocarditis, like MISC. So let me start with the long-term effects, because that's what you asked about. And I think this has been a problem with our narrative about this virus. I all too often hear people characterizing this illness as if it's kind of two ends of a spectrum, two options. One is you have mild or asymptomatic infection, you get over it quickly, no big deal. And the other is you're old, you get really sick, and you go to the hospital and you might die. What we found is there's a whole lot in the middle. And so what we've started seeing is people that previously were generally in pretty good health complaining of disabling symptoms 4, 5, 6 months after infection. That's highly unusual. And this is another area where the analogy to the flu is not apt. This does not happen with the flu. To your point, it certainly can happen with some other viruses, but this is not a common manifestation of respiratory viruses. And so what am I talking about? Well, as you said, we barely have scratched the surface in understanding this, but there is a slight female predominance. And of the very limited studies that have been done, one study showed the average age was in the late 30s, and the other showed it was in the early 40s. So we're talking about, young adults, mid-aged, probably parents. So this issue about high risk people, when we typically think of the elderly and people with a lot of medical illnesses, remember that means high risk for death. What we don't know is who's high risk to develop, they'll survive, but they'll still get these complications or these long-term effects. We do not know. Like I said, there does seem to be a slight female predominance, which is actually the reverse of this severe disease, because what we typically see is men are more severely affected by the acute illness, and men tend to be more likely to die. But in this group with the long-term effects, they tend to be women. They tend to be late 30s, early 40s. And what we often hear is somebody who was very, very active, had a very active life, oftentimes people that were exercising in good shape, and people telling us that they are completely exhausted if they climb one flight of steps. We hear that they cannot stay focused. They can't concentrate. They may have memory problems. They may have shortness of breath. They may have palpitations and fast heart rates. There are a whole myriad of symptoms, and we really don't know how many there are out there. It appears that there are tens of thousands of people from what limited information we have right now. So some of those people have reported that after about 4 months or so, they started getting better. Others are 5, 6 months out and they're still having these symptoms. I remember a young physician in his late 20s, early 30s, and a surgery resident, and very healthy runner, that kind of thing. And he told me that when he got back to seeing patients at the hospital, and he'd have 30 patients to see, he'd have to stop and sit down and rest halfway through rounds. So this is a pretty significant impairment that we're seeing. So that's the long-term effects, and they've been given a name. They're called the long haulers, and we don't know why they're having this. We do not believe that they're still having active virus infection, that the virus is still active and with them. We think this is more likely some kind of result of direct damage the virus has done, or indirect damage that maybe the immune system's doing. We're not sure. The second group that I distinguish from this group is the group that's getting complications. And we have seen a number of very alarming complications. One is blood clots. We certainly have known and have seen people, when they are acutely ill in the hospital, developing blood clots. In fact, we've had people doing imaging procedures that saw new clots even while they were doing the procedure. And so we do know that this virus affects the clotting and makes you much more susceptible to clotting. And there appears to be probably a number of mechanisms by which that is happening. And that is distinctly unusual. We, thank God, don't have many viruses that cause that kind of an effect. And certainly the flu doesn't. So blood clots is one. We've even seen some people in their 30s and 40s have major strokes, which is obviously terrible. The other thing that got a lot of attention recently is myocarditis, which is an inflammation of the heart muscle. And it's mostly been reported in athletes, particularly college and pro level, because what was happening is these athletes were getting infected with COVID, and then as part of the evaluation for returning back to sports, they were getting a cardiac MRI test, a very advanced kind of imaging test that was finding this myocarditis. And interestingly, finding it in athletes who actually had very mild illness. So it doesn't seem to correlate with how sick you were. But one study from Europe showed that they could identify it in 60% of people they looked at. A recent study that came out of Ohio State University, but a very small sample, showed 15%. So we don't know, and we don't know what the significance of it is. Because a lot of these people were getting screened because of the need to return to sports rather than having symptoms. So this is another thing that we're going to need more time to look at. But there's a lot of long-term effects, and then there are some very serious complications.
And these are complications that we're not just noticing because we happen to be paying more close attention to these patients because it's a novel virus and it's being very well studied. These are complications that just haven't been seen in other viruses?
For the most part, I mean, I think for example, the myocarditis thing I talked about, I think we're picking that up because of this novel virus and because we just don't know, and we have this technology now. We actually believe that there are quite a few viruses that can cause myocarditis. And that's something we've known about for a long time. What we don't know is this going to be the same kind of course as for viral myocarditis, which fortunately most people do recover from and do fine? We don't know. What would be the concerns? Well, one of the things we kind of worry about when there's inflammation of the heart muscle is that part of that healing process is it develops a scar. And when you develop a scar, if it's in the right place and if it's big enough, then it can be a site in the heart muscle that can trigger abnormal electrical activity. And so the concern there is, will this pose a risk that somebody might have an arrhythmia, and one that could be potentially extremely serious or life-threatening? We have no evidence of that. And we don't have reason to be concerned that's the case yet, but it's an unanswered question, and we need to look at more of this. It could be that the myocarditis is going to just turn out to be, well, that's interesting, but of little consequence. We just don't know yet, and it's been a highly select group. But the other complications, the strokes, the blood clots, and blood clots going to the lungs and so forth, those are distinctly unusual for a viral infection.
And we do have at least one case of an Idahoan whose life was taken by myocarditis as a result of COVID-19, a nurse practitioner.
That's right.
Right in the Treasure Valley.
That's right.
A young one. So
Yes.
We heard from a lot of readers, this is kind of a theme. They're concerned about not knowing whom to trust, feeling like their trust in official sources has been eroded through this pandemic. What can you tell them? Who can they trust? Who do you trust?
Yeah, well, it's a great question. And certainly recently, it's been, quite shocking to hear some of the tape recordings of the president from early on in this compared to what he was telling the public. And I get his point that he didn't want to, scare the public and all. I think when we're dealing with a novel illness and we need people to take action and take it seriously, we need to be honest with people. And there's ways to do that without inciting panic. You can express to people, here's the very serious challenge we have. Here's the serious threat. But now let me tell you, here's the plan to deal with it. So, it appears clear the president was not honest with us. We've certainly seen, there's been failings of the World Health Organization. I agree. I don't think we should drop out of it because of that. And we can talk about the reasons for that if you want to. But the World Health Organization needs to do a better job. The CDC made some missteps, and they need to learn from that and not make those again. And then also recently, we had the issue where the FDA has let us down several times during this pandemic. And Dr. Stephen Hahn, I believe he's a good person, a well-intentioned person, but he's kind of a novice at running a big government agency. And he succumbed to a lot of political pressure. And whoever's in that job cannot do that. And so that's hurt our trust. And the CDC came out with a recommendation recently that appears to be politically motivated. And so, they've let us down a little bit. The good news is when they do that, there are physicians out there, I'm certainly not the only one, who are willing to speak up and cry foul. And so at least I think the physician community, by and large across the country, is standing up to this and saying when that's not right. But it's hurt our trust. And then, unfortunately, we've had, some physicians out there, unfortunately. There was a very notable case in Texas, in Houston, of a physician doing a video that went viral that was just loaded with misinformation. So I get it that people are losing trust. Here's what I would say, and here's the approach I take. First of all, I try to get my information from people that don't have obvious conflicts of interest. So, there are people who could financially benefit one way or another if people buy a certain stock, get a certain test, do things. I tend to discount people with a conflict of interest. And I think it's very important for anybody who's going to take a stand on these issues to be very clear. Do I have any conflicts of interest, or what are they? And so I think that's one. Number two is look at what the person's saying. Does this match up with what we're being told is coming out of clinical studies? And of course, I have the benefit, I can look at those clinical studies and understand them myself. And so is it squaring with that? Are they being led by evidence? Another thing is somebody willing to admit that they've been wrong? I've made a number of errors in judgment along the way, and I've admitted when I've been wrong. Fortunately, I haven't had too many of them, but I have had a few. And I think if somebody's telling you that they've been right about all of this, that's pretty suspect. I don't think anybody has been right about everything. I also think we need to cut people some slack for being wrong. I had one of my Twitter followers, for example, say, oh, well, somebody told us back in February that we shouldn't wear masks. Well, I was one of them based on what we knew at that time. But we got new evidence. And so I was wrong, but I was right at the time based on what we know. And we need to cut some people some slack, because what we don't want to get to is a situation where people that are knowledgeable, people that are experts say, like when you're asking questions, I'm not going to comment because I'm not sure it's not going to be different a month from now. And then I don't want people looking back and saying, see, he was wrong. That's not a good environment for us to have. We want people to evolve their knowledge as we get more evidence. And with a novel virus, obviously, we're going to be learning a lot more now than we were back in March. And I think that if you can imagine back in February or March, when this was becoming an issue, had the experts that you reached out to said, we're not willing to comment because we're just not going to take all the criticism if it turns out to be wrong, I mean, people would be in an uproar. And I think most people understand that we're going to tell you the best of what we know today. When we get more evidence, when we study larger populations of people, we may come up with a different answer, and we'll tell you then. But I think that's a criteria to use. If somebody says they've been right on everything, discard them. If people say they've never been wrong or haven't changed their views about this, discard it. The other thing is if people are making this political, if people are being guided by things other than the science, it's just because of their political views, and all of us have political views. I have political views, but I do try to keep that separate from, well, here's what the science says. And of course, I've criticized leaders of both parties when they've gotten things wrong, and we need to speak out. So it is difficult, but if you're getting your news from a source, first of all, where the person's not an expert. So I've seen some people share some stuff from me that, I think one of them was like a chemical engineer was giving all this expertise about it. Well, they might be right, but you probably shouldn't trust them as much as somebody who actually is a physician, who actually has some expertise in this area, and has treated patients with this kind of thing and deals with it and doesn't have anything to gain by influencing you one way or the other. It just wants people to have good information.
So we're definitely in the don't know phase with vaccines, very much so.
Yep.
Based on what we know so far about the different types of vaccines in development, where they are in testing, how optimistic are you that we'll have a vaccine? What timeline? Would you feel comfortable taking any of the vaccines that are in development right now?
Yeah.
Putting you on the spot here.
Well, I'm very optimistic. And I think this is extraordinary. People, this process is going so fast that some people are alarmed that means we're skipping over safety and all. I don't share that view. I think the reason why this is going so fast is a number of circumstances. First, after the first SARS, now this is our second SARS virus, but after the first one, there was a lot of work on vaccine development. Unfortunately, our federal government thought once the first SARS was over with, let's not keep spending money on that. That's too bad, because it could have positioned us even better position for now. But all that work that was done back then didn't go to waste. So we had a jump start on this vaccine development. And places like Oxford University in England has been doing a lot of this research that there hasn't been a lot of funding for. So they actually were pretty far ahead. So there were some good ingredients. The second thing is vaccines, by and large, are not where pharmaceutical companies make their money. And vaccines typically have a limited population. For example, the shingles vaccine is kind of for people that are elderly. It's not for everybody. Some of the kids' vaccines, it's really for kids, not for older people. So, but this vaccine, everyone in the world needs it. And so there's a tremendous financial incentive for pharmaceutical companies to actually invest in creating a vaccine. And what we've seen is really an unprecedented, I think at last count, there was like 162 different vaccines being developed and or tested. And the other interesting thing is, excuse me, I'm getting a dry throat. Our technology has come along, and we've got some very new types of vaccines that we're experimenting with. So, for example, Moderna, who has an mRNA virus vaccine. This is the first time we've ever had that. And so first of all, it has the advantage, it cannot infect you. And the other advantage is it's actually easier to produce than some of the other types of vaccines. But we have all these different types of vaccines in trials. No doubt some are not going to work. But this gives us lots of cushion, because all we need is, if we could have 2 or 3 that work out of the 162, we're in good shape. So, and it already looks like that is absolutely going to be likely. So the vaccines that are most advanced are in phase 3 trials, which is the last step in the study. The limited data reports we've gotten from phase 1 and phase 2 trials have actually been quite encouraging. And one thing that people often ask me is that I've been talking about that the immune response from the natural infection that is actually getting the virus isn't particularly robust. Why would a vaccine be better? And that's a great question, but it's because the vaccine can actually be designed to tell the body to make this specific type of antibody, or to trigger a different part of the immune system than what happens with the natural immunity. When you get infected with something, your body tends to make a whole host of different antibodies, and only some of those antibodies are particularly helpful in fighting this. We can actually focus the body's response with a vaccine to produce exactly what's going to be the most helpful. So I am encouraged about the vaccines. Now, the next question is, well, what about the timing? And of course, this morning, we heard the tension between the White House and the CDC. White House saying we're going to have a vaccine, I think they said November. The CDC saying it's going to be like third quarter of next year. And I think we're talking about different things. So understand that when we complete these studies, what happens is that data, hopefully it'll be submitted to peer review journals so that all of us doctors can look at it and study it for ourselves, but it'll go to the FDA. And the FDA will either decide to give the vaccine company an emergency use authorization, which means we're just going to rely on your data. Go ahead, you can do it. Or they can do their own review and give approval of it. And so I think that can happen pretty quick. And one of the things that's unusual about this is that the companies have actually been sharing data with the FDA all along to kind of accelerate this process. That's not what we usually do. Usually you wait till the studies are done and all. So that could accelerate the FDA step. Another big thing is, if you're a pharmaceutical company and you're coming up with a new drug or a new vaccine, you're not going to produce a whole lot of it until you finish the studies to know that it works and you know that the FDA is going to approve it, because otherwise you distribute it and you'll just lose money. In this case, and I've been very critical of our federal government, let me give them some props here. They made a great move and they identified some of the leading vaccine candidates, and our federal government has funded those companies and said, go ahead and produce it, even while we're doing the studies, because that way, if the study comes out good and it does get approved by the FDA, you're ready to go with vaccine. And so that's going to save us a lot of time. Now, the next step is after the vaccine is produced, and then it has to be distributed. And that is that the vaccine goes to the federal government then distributes it to the states. And then we're not going to have enough vaccine right off the bat for everybody to get vaccinated that wants to. So we're going to start with the high priority groups. And so the vaccine will be distributed to the state. The state will administer it to those that are high risk. And it's possible, if everything goes well, and that's a big if, but if everything goes well, it is possible that we could start seeing frontline healthcare workers, first responders, high-risk people in long-term care facilities could be starting to get vaccinated by the end of the year. Now, this vaccine is a 2-series vaccine for most of them, and meaning that you're going to have to get a shot, and then a month later you get another shot. And when you get that another shot, it has to be the same vaccine. You can't get one company's the first one and another company's the second one. It has to be the same one. And so all in all, it's going to take about 6 weeks for you to have kind of the maximum immune response to the vaccine that you're going to get from the time you get the first shot. But that could start happening before the end of the year for these high-risk groups. I don't think enough vaccine is going to be produced and distributed that it can be administered to the rest of us who'd like to get it until probably spring of next year, I'm guessing. I mean, it could go either way. It just depends. But I think most of us should think, we're going to be getting our vaccine spring to summer. And then I think the CDC's right that, by this time next year, probably everybody who wants to get vaccinated probably can get vaccinated. So I think the White House is right. We're going to have a vaccine in November, likely, but it's not going to do as much good because we can't get vaccinated yet. And I think the CDC's right. It's probably going to take that long to get everybody vaccinated. But that's kind of the course we're looking at.
And we have had at least 2 of the vaccines have been doing clinical trials locally. So we do have
Yes.
some folks in the Treasure
Yep.
Valley who are helping to test these vaccines, which is fantastic. Um,
And thank you to those people. We need people to volunteer for these studies so we can tell. So thank you for being willing to do that.
I'd like to talk a little bit more about schools. A lot of folks asked about this. Obviously, it's top of everyone's mind right now. What are schools doing right? What are schools doing wrong?
Well, and it's all over the board. Some schools are doing much better than others. And I want to commend the principals, the teachers, the school staff. It's really been impressive to see how carefully they're taking this and the preparations they're taking. And this is tough because those principals and those teachers, by and large, are not public health experts or infectious disease experts. So this has really been asking a lot of them. And I think they're really doing a great job. I've made no secret of it that I've been disappointed in many school boards. Some have done a great job. Some have not. So my first critique is I have been very public. I don't think doctors should be deciding whether a school opens. There's many more considerations than just the medical ones. But on the other hand, I have criticized school boards that haven't seemed to give the medical and public health information due consideration. You should try to learn about it. You should consider that. There might be other reasons that would cause a school board to conclude, well, we're not going to go with the medical advice because of this. But I've seen, I can't even think of one, a school district that's going against the public health advice that has clearly articulated for everybody, we're not going to go with that. And here's why. And some kind of well-reasoned argument as to that, because I don't mind if we look at the same facts and we come to different conclusions. As long as it's well-reasoned, okay, reasonable minds can do that. That's fine. But tell us your reason. So that's the first thing. With respect to the schools themselves, probably the biggest thing that's going to depend. There's probably 2 factors that are going to be the biggest determinants as whether they're successful, whether they can keep the schools open. One is the degree of community spread. And the reason that that's important is that just determines how likely is it a teacher, a staff, a student shows up to school infected. And the more people that show up infected, the more likely you're going to have a problem. That's not terribly complicated. The second thing is, how well thought out are their operational plans? And we learned this in healthcare. There are a million issues you have to think about to manage this pandemic. How do we keep our staff safe? How do we keep our patients safe? What are the procedures we need to do? And healthcare has been on that forefront because they've had to, and they've done a good job of evolving this. Schools have had time. They've been closed down largely since March. They've had time to come up with these plans. And the biggest mistake I see is plans that are not detailed enough. They don't think about, they may have great plans for what we're going to do in the classroom. They don't think about the risks that are posed out in the schoolyard before school even starts. They don't think about education of students and parents. They're not very clear about whose responsibility is it to do this or that. And so a lot of times I find it's just they're not very detailed. The most common misstatement in these plans that I see is a provision that face shields can be a substitute for face masks. They are not. Face shield has actually started out being used by healthcare professionals. And the reason is when you wear a mask, it doesn't protect your eyes. And so the face shield comes down over and helps protect your eyes, particularly for medical professionals that are going to do procedures to patients that may cause them to cough and or otherwise have virus hit their face, which is not as big a risk for teachers. But a lot of teachers who don't want to have their mouth covered, and I understand, I get it, but I think there's a false sense of security that, okay, I can just wear a face shield and that will be protected. It's not. So I think that's one of the biggest errors in these plans. I think the biggest disappointment is that schools haven't asked more for help. I know Dr. Nasser out at St. Al's has been helping the Boise schools. I've been helping some of the other schools. But a lot of schools just haven't asked for physicians or public health experts to help them look at their plans and see if they're adequately covering everything. So that's probably the biggest difference I see.
So schools, if they want your help, can contact you?
They can. I do this as a voluntary activity, and I am retired, so I'm not looking for a full-time job. And I'm happy for them to. Some probably don't want to use me because I've been so outspoken about their school boards. So I'm happy for them to contact somebody else. And there's lots of people they can turn to. But what my big purpose was, I didn't want to criticize the school boards and then do nothing to help the schools. So I said, look, I've made my criticism of the school boards clear, but schools, if this is what the decision is, let me help you. And I don't want money to be in the way. So I don't ask them to pay me anything, and they don't. But I say, hey, I'll help you. Let's just make the best go of this that we can. And I think having fresh eyes and a different perspective helps. But they can turn to lots of physicians. They may have parents that are physicians, public health experts, whoever. I just think they ought to get some another perspective and some more detailed advice.
Okay. We have a question from Lynn Poling, and I think this is a question probably a lot of other parents are going to be asking too. Kids going back to school, what if you have a child that repeatedly has strep, bronchitis, asthma? Should these children return to classrooms prior to a vaccine?
Well, it's a tough question. The big problem about all the illnesses that we're going to deal with during this fall is many of them are very difficult to distinguish from COVID. And so if your kid frequently gets sick, this is going to be a challenge because every time they get sick, is this the usual stuff or have they now got COVID? That's a big challenge. I would say if the child is frequently getting sick and severely getting sick, I would consider maybe that child needs to do remote learning if that's feasible for you. Now, the thing we can hope for is what we did see in the Southern Hemisphere is when there was good compliance with the distancing and wearing masks, not only did COVID go way down, but a lot of these other respiratory viruses went down as well, because many of them are spread in a very similar fashion. So if they're going to a school where the school is very good about requiring masks, requiring that they be worn properly, that they always be keeping their distance when they can. If the school's very good about this, actually, you might end up having a good fall and less illnesses than usual. But I think you're going to have to make an individual decision for your child with that child's doctor. How much of a risk is this? How problematic is this going to be to determine whether your child should be in person or maybe ought to be remote?
So we've got some other kind of specific situations folks are wondering about that I think probably a lot of people are. Debbie in Boise asks, is it safe to return to a small gym with safety protocols in place?
So I assume we're talking about, one of the commercial gymnasiums. I guess that's probably what they're talking about. I'm knocking on wood. We have not had a particular problem with outbreaks at gyms. Now, other places have. And so I think a lot of it's like schools, the devil's in the details. What's their operational plan? What are they doing? The particular things that we have to worry about at gym is distance is even more important than in school. And the reason is that we do know if you're breathing heavy and fast and you happen to be infected, you are going to transmit more virus in your droplets and a further distance. So if it was a gym that was keeping people 13 feet apart instead of 6, I'd be more comfortable with that. The other particular risks that we have to worry about in a gym is people tend to go from one thing to another, and therefore they're touching things somebody else has. So a lot of it depends on what's the cleaning protocol. How do these things get cleaned down between use? So that's the second thing I would say. Then the third thing I would say is this whole issue of airborne transmission, which we really don't totally understand right now. But certainly, if it's an option to do workout activities outside, obviously that's best. That's not going to be always practical. But otherwise, if it's going to be indoors, lots of spacing. And I would talk to that gym about what are they doing for the air circulation and filtration. If the air is not recirculated, and if it's pushed outside, and if there's frequent air exchanges, that's going to be better.
Marty from Boise asks, I know that outdoors is safest for being around other people, but I'm thinking about when the weather turns cold soon. Is it safe to gather with a few friends in a garage with the garage door open and a side door open?
Garages typically don't have very good air circulation. That would be what my risk, what I would be concerned about. And this is why I responded to you earlier, Audrey, when you asked, why do I think things are going to get worse with cold and flu season? It's because we're going to be moving indoors. So anytime you get indoors with people you don't live with, you're taking on risks. And the more community spread there is, and like I said, I expect that's going to be going up soon, then the greater risk it's going to be. So certainly being in a garage with the garage door open and the side door is okay, but the garages still don't tend to get a lot of air circulation. So if you're going to hang out with friends in the garage, wear masks. I frankly think you'd almost be better off to go in the house because at least you've got the hopefully some air circulation, but lots of distance, wear masks if it's someone you don't live with.
Okay, so go inside, try to get air circulating as much as you can. Maybe have your windows open, practical ways for people to be able to spend time with loved ones when it's the middle of winter.
Yeah. Well, it's going to be a huge challenge. And that's why I say the risk is going to significantly go up. So I think just as a general rule, if you do it outside, do it outside. That's better than inside. If you have to be inside, put more distance. And if you have to be inside, decrease the number of people because the more people, the more likely somebody's going to actually be infected. And if you can, and you're inside, I'd wear masks if they're not people you live with. But I do think we just have to, I don't think we're going to have to keep doing this for a real long time, but we do need to keep doing this, keep up our stamina to prevent this. Just give me 6 months, people. Give me 6 months, and I think we can get to the other side of this. But we're just not going to be able to have. You can't have big weddings. You can't have big holiday parties. You probably need to be careful about trick or treating. There's just a lot of things. We're just going to have to use caution. It's going to be different this year.
So we're nearing the end of our program. I'm hoping that you can kind of real quickly leave us on a positive note. What are you hopeful about? What's given you confidence the past 6 months?
The first thing is the state of medical science. This has been amazing. And for those of you that aren't physicians or scientists, let me tell you, it's just spectacular what is happening in the field of medicine. So, we've always thought America had that advantage. We do. We haven't leveraged it well because of political considerations, but medicine and science has been amazing, and we're going at fast rates. Second, very optimistic about vaccines, very promising about that. And third is just the more time we have, the more we learn, the more we know, the more we can prevent this. I'm also very excited about some therapeutics. There are some very fascinating, interesting drugs to treat this that are under investigation that I think have high promise. So I am encouraged. It's a bummer right now, but it will get better.
Great. Thank you so much. Thank you, Dr. Pate, for talking with us today about the impacts of the coronavirus in Idaho and what's next. And thank you to our viewers and readers for joining us and giving us great questions. You can find more COVID-19 coverage at idahostatesman.com/coronavirus. My name is Audrey Dutton, health reporter for the Idaho Statesman. You can support community conversations like this and local journalists bring you the latest news and information on COVID-19 with a subscription to the Idaho Statesman. Just go to idahostatesman.com/subscribe. Have a good afternoon and thank you.